This is coronary perforation, yes. Thank you, Dr. Musa, for Dr. Abdullah, Dr. Fawaz, Dr. Khalid, for organizing committee. It is actually always a joy to see our friends and brothers from all the Arab countries, especially in the Gulf. My mission today is to talk in over 15 minutes, I think. I have 15 minutes to talk over the overview of the coronary perforation. And as you know that coronary perforation is a rare complication for PCI, but it is a life-threatening condition. And the best way actually to understand the perforation and to manage it is to go and classify them according to the location, severity, and the hemodynamic impact for the perforation. And a very important entity these days is the dry tamponade. We will talk about it. So the early recognition and prompt intervention is the critical way and the important point to avoid morbidity and mortality. When we come to the location, the location either to go in the main vessel, to have the perf there, or to have it in the distal vessel, or to have it in the collaterals, either the septal or the more dangerous is the epicardial collateral. And as you see here, an examples for them where you have the perforation from the main vessel or at the exit with the wire or from the septal collateral or the epicardial collateral. And when you class them to the severity, the most used classification is the Ellis classification, where you have the type 1 where you have still the crack in the wall of the vessel and still the perforation is contained in the structure of the vessel. And in type 2, where it reached to the, still in the tissue, but outside the vessel, either in the pericardium or in the myocardium. And once it starts to extravasate outside to any chamber or to the pericardial space, we call it type 3, and type 4, type 3, type 4, when you have collection or perf to the any chamber or space outside. So the initial management universally actually is to go, the first thing to do is to stop any anticoagulants or antiplatelet running in the cath lab, so you need to stop it. Sometimes you need to reverse, but be very careful when you reverse. You need to reverse it if you did not deploy a stent yet. After deploying a stent, there is no place for reversal unless you have something very crucial. But usually, we don't reverse when you have a stent already deployed. The hemodynamic assessment is very important and essential for life saving, and this is, we will talk about it in some details. And the first thing to do when you have perforation is to inflate the balloon. Inflate the balloon in the vessel in that branch, so you will stop the bleeding from that perf. And in type 1, in type 2, you go with the balloon tamponade from inside at the site of the perforation. You may tamponade it and you stop it. While for Ellis type 3, you need to go back proximal to the perf, so you need just to stop for a while of time the bleeding and to gain some time to have hemodynamic stability either by pericardiocentesis or by preparing your cover stent. So the important thing about the pericardial drainage, these days, this is very important and supported by the literature, is the early pericardial drainage placement. So when you have type 3, don't wait till you have tamponade to establish your pericardiocentesis. You need to go with the pericardiocentesis before even the patient develops hemodynamic instability, because this patient will have catastrophic end with cardiac tamponade. So put and establish the drain before the patient developing tamponade. This is a scheme how to go with the management, and in type 1 and type 2, you need to inflate the balloon. It is 1:1 actually the size, and it is for 10 minutes, just not to inflate it too much, it's 2 to 6 atmosphere. And to go and prepare for your cover stent if you failed. In type 3, there is no place actually for balloon tamponade. You need just to stop the bleeding for a while of time till you, just to gain time for for having the cover stent there. In type, and when you have a distal or exit wire perforation, there are many ways actually to go and block it or to close it, and there are a lot. Any particle you can use it, either a clotted blood, subcutaneous tissue, fat embolization, thrombin, glue, gel foam can be used. All of these things can be used till you have a coil, which is really the last destination or the best destination actually to do. The covered stent, you know, their problems that they are bulky and they have high incidence of in-stent restenosis and thrombosis. And the very important point about them is the guide catheter. Please be sure that what you have in your shelf, either Graftmaster or Bavarius, they are the most common ones to use. You need to have the catheter which you can deliver your graft stent in. When you have a big graft stent as a Graftmaster, you need sometimes 7 French guide catheter if you have it more than 4, for example. So be careful about when you deliver your graft stent that your catheter fits in. How about the coils for distal perf? You need to go with the coil embolization, fat or clotted blood or whatever. And in CTO, one of the CTO maneuvers to do is the subintimal recanalization. And you can use the flap either by retrograde or antegrade and use it as a flap to close the perf. Pericardocentesis, go with it early and don't hesitate to call a surgeon if you need. The coils, you should have something that you are expert with in the cath lab, and they are either detachable or pushable. And whatever coil you have, you need to have the experience and know how it works and to deploy it. And never mind actually to have the experience of the neurointerventionists. They are doing lots of coils, so you can ask their experience. One word about the dry tamponade, which is an entity actually will be the CTO operators, they see it more, especially in patients after cabbage and you do CTO for them. They have a localized hematoma in the epicardium or intramyocardial or in subepicardial space, and it is not reaching to a space. Here in dry tamponade, we call it dry tamponade because there is no collection, no fluids there, and it is not the way to aspirate it. And these are examples. Here you don't see any pericardial effusion. Here you have in the right ventricular wall hematoma like this one, and it causes the same problems physiologically as pericardial effusion, but it is not there. And here you have the septal hematoma for this. This is an example for septal hematoma. In this case, it is not the way actually to go and do pericardocentesis or drain fluids because there are no fluids there. So you need to stabilize the patient hemodynamics. You need to go with the echocardiography and more images if you need CT or MRI. And you need to reverse the anticoagulation. Here, usually they do not deploy stent yet. So you can reverse whatever, either NOAC or heparin or whatever. And the definitive management actually is surgical in this case. We may go with a thrombin injection if you know where is it, and to go with that and inject a thrombin. Or you do CT-guided drainage by an interventional radiologist, and to go there and drain from the heart. And the definite destination of management is the surgical intervention. Keep the patient monitoring, and sometimes you need even a mechanical cardiac support device. These are the references of my lecture. I'll just give you 2 examples of unusual way of treating perforation. This is the main vessel, this is in the LAD, and you can see that the stenosis is mostly in the mid-segment. I have started there with the dilatation of that segment, and after dilation, you can see this perf. So the way to do this is to go with balloon tamponade immediately and to have the graft stent and to deliver it there. Sometimes you don't have graft stent or the proper size, or as in this case, we have still proximal lesion. To go and dilate that proximal lesion, or to be able for the graft stent to cross, because the graft doesn't cross when you have a lesion like this, in the proximity. So to dilate, to able to cross, this will increase the flow to the vessel and increase it. No, you don't want to do this. So in this case, we did the regular stenting, and after the first stent, there is the reduction, and another stent was deployed at that area, and the bleeding stopped before even dilation the proximal segment. So in this case, 2 stents, 2 DS stents stop the bleeding. The another case, this is a patient with, as you can see, the bifurcational lesion, and here in this case, 2 wires and DK crush to fix this lift circ and OM. And as you see here, there is some stain. The wire was there, and this stain was observed. I liked that time just to keep observing and checking by echocardiogram. There was no pericardial effusion, so I expect this is just type 2, it is just in the tissue. And this is a failure. Always when you have perf like this, always consider that you should do something and fix it and not to leave it. Why? Because even if you don't have pericardial effusion by echo or by echo or by inside the cath lab, but when you have something like this, it is not stable staining, you need to do something. This is what happened, unfortunately. After 1 hour, the patient crashed down, he had hypotension, pericardial effusion. So the first thing, we did pericardocentesis, drained the pericardial blood, and stabilized the patient. And then what to do? I have tried many things actually here because the coil was not present. So you can see it here. Sometimes to localize it very well, you need to go and do tip injection by the microcatheter. So tip injection by microcatheter to localize where is that exit perforation. So I did many things actually here: surgical suture, subcutaneous tissue fat, clotted blood, but actually I was not able to find out exactly where is that perf, and the perf continue there. So then I start to have particle of the balloon, the tip of the balloon, and tip of another balloon, and I try to fix that perf. I did the first one, it did not stop it. I cannot find exactly which branch is it, from where is it exactly. So 2 parts, 2 balloons actually were deployed there. Unfortunately, it failed. And the perf still continued to ooze. So the last destination for me was to use the gel foam. Gel foam was used, and here I trapped the microcatheter by a balloon to hang to avoid the back leakage of the gel foam, and then deployed well, or I inject that gel foam, the bleeding stopped in this way, no more effusion. And the good thing about the gel foam, after 3 weeks, I did the CT scan for follow-up, and it reperfused and recanalized again, and the vessel is there. So these are 2 examples of unusual way of treating perf. So my conclusion for the patient with perforation, this is catastrophic problem, and you need to have the stepwise approach. The balloon tamponade is very important. Pericardocentesis is very important to be established, and you should have a cath lab prepared very well with all the tools and the instruments that you need to fix. Thank you.